We do a lot of immediate tooth replacement in the aesthetic zone. There's different techniques that are involved that can give you consistent outcomes and predictable outcomes. I know it's going to be a little controversial because I know in different parts of the world, there's different philosophies of either immediate implant placement, early implant placement, late implant placement. So I think it's going to be a very interesting discussion. I won't focus on how to fix them, but I'm going to focus on maybe how we can avoid them. But clearly you could see here a patient like Denise, that she's lost the papilla and she's lost the midfacial tissue. She had an immediate implant placed for tooth number 11. And you can see here some of the problems associated with the placement of that implant. So let's talk about the implant risks. And some of the risks that potentially we would encounter is with immediate implants in the aesthetic zone is risk of apical socket perforation, also loss of the labial plate over time, and loss of the interdental papilla. And those are really the three main risks that we have to be concerned about. And equal importance, how do we avoid these problems and some of the solutions that we would have. Here's Lillette. She came into our office. She has a tremendous amount of inflammation associated with tooth number 11. You can see here the soft tissue response that she has. And if you look at the CBCT, this implant is placed in the perfect restorative position to allow for screw-retained restoration. The implant is not very long. It is a little bit wider. It's probably wider because they couldn't get length for primary stability, and maybe they wanted to avoid socket perforation, but the bottom line is that that implant has perforated the apex of the socket. And when this case was flat-backed and remediated, I'll show the remediation tomorrow, is that because there was an apical perforation, then there was sequestering of the remaining crestal bone around the implant because the blood supply was compromised by the implant perforation. So these are obviously cases that we want to try to avoid. There has been more recent studies that have really brought to light the importance of implant positioning and also the risk of apical socket perforation. Again, basically saying the same thing, that the ability to deliver a direct screw-retained restoration was only on the order of, say, anywhere from 10 to 25% of the time. That would mean that, conversely, the risk of apical socket perforation is on the order of anywhere from 76 to 90%. These are papers that, as an aggregate, really reinforce the concept and the risk for socket perforation. So obviously, this is something that we want to avoid. And that would mean that in order to potentially avoid the socket perforation, that implants now have to be placed not at the cingulum, but more toward the incisal edge. For those of you who place implants, you know that the risk for midfacial recession increases with placing implants more with the facial placement or facial angulation. So it's a very delicate balance between the surgeon placing implants to avoid socket perforation at the apex, yet being able to aim it to the incisal edge slightly to potentially then allow a restoration to be made. So now if implants have to then be adjusted in its placement and angulation, then, what are some of the choices we have from a restorative standpoint? Well, we can do a cement retain. We can use an angulated screw channel abutment, which are very popular nowadays. You can use an angulated multi-unit abutment. This is maybe a little bit more questionable, but for a single tooth, I'm not so sure. I haven't really tried this, but this is clearly an option. Or you can use what's called a coaxial implant, which is really a surgical restorative discussion and selection. And but it's something that we use quite a bit in the aesthetic zone. If I look at angulated screw channel abutments, I'm going to try to condense all the literature on this topic. So what are some of the limitations of angle screw channel abutments? And one of the issues is Chandor Wadnati published a very interesting paper with Offler. And what they showed is that the threshold of angle correction, how much could I correct an implant that was off-angled, a uniaxial implant with an ASC abutment. And they found that the threshold was about 15 degrees, and anything beyond 15 degrees of correction would potentially lead to an increase in screw stripping. So they showed that pretty well, that the threshold is about 15 degrees. They showed that ASC abutments that are off-axis loaded with the same amount of fatigue loading fail twice the rate as direct screw channel restorations. That was sort of interesting. It makes sense. And there are studies to show that when you load ASC abutments, basically the screw is being loaded at an off-axis, that the rate of screw loosening also increases. So you just have to be aware that all these different variables put other issues at risk, and consequently we have a higher rate of potentially screw loosening as well. So what about sort of this surgical restorative solution? You know, what is some of these other options? And I'd like to really talk about the coax implant, which has been around for over 20 years. You, as a surgeon, should care about what the outcome is, because you want to reduce the risk of apical socket perforation, which I told you is very high, yet you want to be able to deliver a screw retain restoration without all these other things that we have to deal with. So how do these coaxial implants work? It's very simple. The prosthetic platform has an angle correction built into it, and then they have a matching implant mount that matches the prosthetic offset. So most anteriors are about 12 degrees correction. They have a implant mount that matches the 12 degrees. So the implant mount is at minus 12 degrees. They usually come pre-assembled, so you don't have to think about where is the orientation of the implant. So they have pre-mounted implant carriers, and once it's assembled in the proper position, they spin at 0 degrees. And it works incredibly well. Incredibly well. And the reality is, this is a much more elegant solution to the problems that we have with ASCs. If I just went through some of the advantages and disadvantages of this, this is sort of a table to say, okay, what about, cement retained or retrievability of restoration? So custom abutments, cement retained, sometimes the retrievability is not so easy. The screw comes loose, then you sometimes have to destroy the crown, so it's not so easy to do that. Angle screw channel gives the ability to have some retrievability. A multi-unit, maybe angulated abutment for a single tooth may allow that to be. And clearly with coaxial implants, you have the ability to retrieve because it's direct screw retain. Screw loosening, an abutment, again, custom abutment. I've had some screw loosening with them. Angle screw channel, you can get screw loosening. Multi-units that have maybe smaller for a single unit, potentially it's there. Coaxial implants, I think the risk of screw loosening decreases. Screw stripping, cement retained restoration, I don't really have that as an issue when I make a custom cemented abutment, so I'm not really concerned about screw stripping. I have stripped some ASC abutments. Maybe, I'm not sure about a multi-unit abutment. And no screw stripping with a coaxial implant. Compromised structural integrity, maybe yes for the ASC, the other ones probably not. Technique sensitive, I would say yeah. Doing a cement retain, it has to be a proper design. And how to use cement, I think it's very technique sensitive. Angle screw channel abutments are also technique sensitive in how they're fabricated as well as how you insert them. And coaxial implants, They're technique sensitive from a surgical standpoint because the surgeon has to learn how to place those implants. So it's technique sensitive from the surgical side. So there is some learning that's involved with that. Again, angle correction, most of them are at the abutment level, but coaxial implants are at the implant level. And what are some potential issues? You know, there's biologic issues with the cement, maybe with ASCs, as Stefano said, there's debonding of the superstructure, you know, maybe micro leakage of some of these other issues. And but the coaxial implant definitely has a benefit of giving you greater peri-implant soft tissue. So that's sort of my summary of some of the issues we would have in being able to deal with you know, some of the solutions, some of the issues we have in the aesthetic zone, some of the risks, and clearly how we sort of approach our anterior aesthetic cases. We would prefer doing coaxial implants, but it took us some time to do it. We've been using it for the last 8 years, and it's definitely our go-to in the aesthetic zone because we've learned how to use it and we understand the benefits.